Hello and welcome everyone. Today we'll be discussing about the mimics of sepsis. Sepsis is a very common presentation in our ICUs. So, this particular case, a 40-year-old man presenting with fever, cough, and infiltrates on the chest X-ray. This is a very common case that we regularly get in our ICUs. Most likely a pneumonia, and we will start treatment for it. By day 3, we are starting to get some problems. Now the renal function is slightly worsening, the platelet count is going down, and the shock which was initially resolved is again starting to come. Now, this is not something which happens in all patients, but still it does happen in many of the patients. So what we do mostly in this case is escalate the antibiotics, chase our cultures. So if the cultures they come negative and the patient's parameters are not showing much improvement even after escalating the antibiotics, this is where we usually stop thinking. And we only believe that it's the escalation of antibiotic is the only answer to this particular scenario. Now, it is time we should take a pause and think about something else, because sepsis is after all just a label. It's not really a diagnosis. So when you have a patient of sepsis and you see features like this, where the patient is not improving and some parameters are going haywire, then don't just think that escalating antibiotics is the only solution. Take a pause, think a little, you will surely find something else is there with this patient. Sepsis is defined as a life-threatening condition where the body's response to infection causes an organ dysfunction. Sometimes similar organ dysfunction can occur with non-infectious causes also. These are called the sepsis mimics. Now, even in sepsis, we have to find out where is this infection. So these are some of the common organ dysfunctions which we find in sepsis. Your lung can be affected with impaired gas exchange. Your liver function may be deranged with increased bilirubin and transaminases. There may be thrombocytopenia, complement activation and coagulopathy. In kidney, there can be renal failure and fluid overload. In brain, you can get delirium and somnolence. And the cardiovascular system, you can have shock, capillary leak, reduced myocardial contractility. However, this particular group of features can be seen in other cases as well. Sepsis can cause different patterns and severity of the organ failure, as we saw. Now, scoring systems like SOFA may overestimate the acute severity if you actually don't separate the chronic problems from the new organ dysfunction, because patients can be having a chronic kidney disease. It is very difficult to know from immediately assessment whether it is acute or chronic in onset. Now, treatment for sepsis can themselves cause new organ dysfunction like fluids, antibiotics, the various things that we do, they have their side effects. Now, we have different types of variations in all the organs that we saw till now. You can have different grading and different type of effect on various aspects. So some difference in sepsis presentation is due to the genetics as well, but then exact genes and what variations are there is not yet known. This is just a speculation. Now let's look at the mimics. These are very important things and must be kept in mind. The first one is macrophage activation syndrome. Now what exactly is this? It is a severe life-threatening complication seen in some inflammatory or autoimmune diseases. Now, commonly associated with systemic juvenile idiopathic arthritis, adult onset Still's disease and SLE. Now, can also be triggered by infections, especially viral infections. So, it must be kept in mind. Infections can also be a trigger for macrophage activation syndrome. Now, what are the diagnosis and tools we have? Diagnosis is very challenging, especially if there is no prior history of any autoimmune disorder. Clues lie in a persistence of the fever, a high level of ferritin, cytopenias, liver dysfunction, and abnormal coagulopathy. But mind you, again, significant overlap with sepsis does remain. Bone marrow biopsy will show you hemophagocytosis. That would be a very important diagnostic criteria. The H score is a tool which we use to find out the likelihood of mass. Now, the next is pathogenesis. How does mass develop? Mass involves the uncontrolled activation of the immune cells, that is the macrophages and the T cells. It results in massive release of cytokine syndrome, the cytokines, resulting in a cytokine storm, causing inflammation and damage to the organs and the blood cells. So basically, it is absolute lack of any control in the immune response. So all the cytokines are going out and they are causing a dysfunction in the body. Mind you, this happening in a background of infection is what is sepsis. But this can happen without the background of infection also. And it can be genetic when it is triggered by, again, infection and autoimmune diseases. And the defect in natural killer cells and cytotoxic T cells are common in genetic forms, leading to an unchecked immune activation. Now, some patients have known gene mutations which puts them at a higher risk, but not all cases have a genetic link. So it must be kept in mind. Many of the cases would be secondary, and one of the most common causes of secondary again is sepsis. So again, a lot of confusion and problems. How does mass differ from your typical sepsis? This is what, because as you can see, there is a lot of overlap with infection and mass. Now, both will have your fever, low blood counts, and organ failure. Now, mass is often linked with autoimmune disorders, but this is not the case always. But then, if you have a link with autoimmune disorder, you can start thinking about this particular thing. Now, some infections are again known to trigger mass. So, if you have those infections, like viral infections with Epstein-Barr, you can start again thinking of mass. Cytokine levels can be high in both, but sometimes even higher with sepsis. But then, very difficult and non-specific point to differentiate. If you look at the management, again, there is no universally accepted treatment. Most evidence is still with experience and no real trials exist. Steroids and cyclosporine are standard fast-line therapies. In severe cases, etoposide and plasma exchange may be used. Targeted anti-cytokine therapies are being studied, like for COVID-19 associated. We have been using tocilizumab and have found significant benefits. So again, a specific group, specific type of cytokine and an antagonist may help. So further research in those lines is required for other types of infections. So if you are suspecting this, then suspect mass in patients with autoimmune disorders who show sudden worsening with fever, low blood counts, and high ferritin. Rule out infection, but then remember, infection can be a trigger. So infection being present doesn't really rule out a mass. Use H score, which is very commonly used, and start steroids promptly and add the other agents as and when it's needed. Consider mass in sepsis cases not improving with antibiotics, especially if they are having a liver dysfunction and DIC. Next is hemolytic uremic syndrome. What is this? It is a condition which is marked by the destruction of the RBCs. That is, there is a hemolysis. Associated with this, you have low platelet levels and a kidney injury. Again, mind you, all these things can happen in sepsis also. What is typical HUS? It usually is a syndrome which follows a diarrheal illness caused by E. coli producing the Shiga toxin, and it is seen mostly in children. This is what we term as the typical HUS. Now you have atypical HUS when it is not related with Shiga and it is caused by genetic and acquired problems. And these problems can be with the complement system. We have a more detailed video on HUS. If you want, you can take a look at it. Now, what are the causes and risk factors? Atypical HUS is linked with rare genetic mutations, but then you have a lot of genetic mutations, but most of them do affect the complement proteins. Up to 60% of the atypical HUS cases have a known genetic variant. And now can be triggered by certain infections, drugs, and environmental exposure also. It is extremely rare, but does happen, especially in adults. In children, it is much more common. Why it is so often missed is because in critical ill patients, as we have already said, sepsis can present with all these things. That patient will have a AKI, they will have a low platelet. So it is usually not suspected until and unless other things have been ruled out. So this is an example of a center with over 20% sepsis patients with AKI and severe thrombocytopenia. Only 1% were actually diagnosed with the atypical HUS or TTP. Now, how to suspect it? Consider atypical HUS if patient is having AKI and low platelet. Now, where DIC and TTP are unlikely, this must be kept in mind, especially if there is evidence of hemolysis. That is, you have cystocytes in your smear, you have low haptoglobin and high LDH. So, next is comparing it with DIC. In DIC, you will have blood clotting is disturbed, especially you have a high INR, while in atypical HUS, you will more have microangiopathies without any marked clotting disturbances. If you compare with TTP, TTP is diagnosed with severely low Adams 13 enzyme, which activity is usually normal or mildly only reduced with atypical HUS. Now, always check for atypical HUS if a septic patient develops AKI and unexplained severe thrombocytopenia, particularly if the lab evidence of hemodialysis is present. Now, if you find all these things, then it is relevant to think about atypical HUS. Now, look for cystocytes and peripheral smear. This is very important, but the absence doesn't actually rule out atypical HUS. Hemat consult early is very, very important. This can be life-saving. The third sepsis mimic is endotoxins or endotoxic shock. Now, what is it? Endotoxins, these are the lipopolysaccharides of the bacteria. It is a component of the outer membrane of the gram-negative bacteria. It is highly immunostimulatory in humans and can trigger all main features of sepsis. And humans are extremely sensitive to it, especially if you compare it to other animals. Endotoxemia can result from a severe gram-negative infection, antibiotic killing bacteria and releasing of the LPS, breakdown of the gut barrier. Immune response to endotoxin is rapid and severe, activates immune cells and releases inflammatory cytokines, causes tissue injury, damp release and triggers coagulation. Now, relationship with other syndromes is endotoxin can trigger both MAS as well as atypical HUS, especially in genetically susceptible individuals. Persistent exposure to endotoxin can worsen organ dysfunction and lead to irreversible failure. Detection and lab testing. Endotoxin assay is done. This helps in detecting high endotoxin levels in the blood and it is linked with worse outcomes. Not all cases of sepsis have measurable endotoxemia, but when present, the mortality risk is very high. The treatment approaches are pharmacological. Early attempts focus on antibodies against the endotoxins, but the results are disappointing. Hemoperfusion, polymixing B hemoperfusion filters have shown some benefits in Japan and Europe, mainly in patients with severe organ dysfunction and high endotoxin levels. Trials show mixed results, benefits been greatest with the sickest of the patients. Treat underlying infection, maintain organ support and correct shock until and unless you have some specific therapies available for the endotoxin. So to summarize, this is a practical checklist you can have in your bedside where you suspected like that patient we had. You look for these suspects and look at a checklist, see why the patient is not improving. So if you have no improvement to antibiotics by day 48, you look at ferritin levels or cytopenias. Then you look for AKI or thrombocytopenia without any history of or evidence of DIC. Mind you, for DIC you will have a coagulopathy. So you are not having any coagulopathy, you are having a thrombocytopenia, you are having AKI, or there is liver dysfunction with DIC. So all these things look into something as a mimickers. So remember, sepsis is a syndrome and not a final diagnosis. MAS, atypical HUS and endotoxemia have some unique clues they give for the diagnosis of the condition. Delayed recognition can cause life, and pattern recognition and curiosity is essential. So to close, remember that sepsis is just a level. Your job is to question that level when things do not fit in. Mind you, if they are fitting in, then everything is fine. But if the things do not fit in, don't just escalate the antibiotics and go to rest. Look deeper, recognize the patterns, and because in ICU missing the right diagnosis will cost life, this is very, very crucial for your practice. Thank you for your patience.